Well, we thought we'd start by just introducing ourselves, and then the next part is that we've got a video to show you, and then we've got a bit more to talk about after the video, and then some questions and answers. So I just need a quick technical conversation with Naomi. Do you want me to play the video, Naomi, or are you? I've got it ready to play.
Either way, yeah, you can
Right,
play.
okay, so we'll do it off mine, that's fine. Just so we don't both start the video at the same time. Okay, so I'll go first and introduce myself. So my name is Jacqueline Grout, and I'm a senior healthcare analyst with the strategy unit.
I'll go next. I'm Naomi. I am head of health analytics at the British Heart Foundation.
Stephen Wyatt is here as well. Oh, there he is.
Hi everyone. Can you hear me okay? Yeah. I'm in a bit of a shared space in a meeting room, so apologies if it's a bit noisy. I'm Stephen Wyatt. I'm head of research and policy at the strategy unit. Pleased to meet you.
Okay, so the first thing we're going to do is play a video that we've pre-prepared to introduce the tool, and then we'll talk some more after the video. Just trying to get it sorted so that I can play it out. There we go. Give me a thumbs up if it's working, so I know I'm not sitting here thinking you can see it when you can't.
Yeah, we can see it.
Did you click the sound thing as well?
Hi. I'm Naomi Hertz from the British Heart Foundation.
Hi, I'm Jacqueline Grout from the strategy unit.
And we're here to introduce you to a tool on cardiovascular health inequalities in the coronary heart disease pathway. So cardiovascular disease is strongly associated with health inequalities, contributing to around 1/5 of the life expectancy gap between the most and least deprived quintiles. When we talk about the most and least deprived quintiles, we're using the index of multiple deprivation, which is the official measure for deprivation in England. It's not limited to a simple rich or poor dimension. It looks at several dimensions, including things like crime, environment, health, and a few other areas to determine what the most and least deprived areas are. The work also uses the relative index of inequality, which indicates the extent to which the rate of an activity or event varies across socioeconomic groups. A big crucial point of this work is that it breaks down inequalities across the coronary heart disease pathway. So instead of only looking at people who have CVD or those who die with CVD, we're looking at risk factors through to diagnosis, referrals, and cardiac care. To better understand exactly where these inequalities are happening. So now Jacqueline's going to take us through the tool to show us how to navigate and understand the charts that can ultimately be used to look at where the inequalities are in each integrated care board.
This is the tool that we've built, which is aimed at visualizing the socioeconomic inequalities in the coronary heart disease progression and pathways. The chart in the tool illustrates the relative index of inequalities for each metric that we've considered on the coronary heart disease pathway. And it enables comparisons to be made between the individual metrics along the pathway and to illustrate at which points along the pathway the inequalities are the greatest. And as part of the tool, we've included a notes section here and a definition section here. And so the definition section provides detail about all the metrics that we've used, where we obtain the data from, and the methods that we've used for each of those metrics. So if you want to read about those, that detail is available from this metrics definition tab here. The notes tab gives you an explanation about how to understand and interpret the chart, which I'll go through in a second. And then this main page of the tool is where you can look at the tool and consider it by ICB. So in terms of understanding and interpreting a chart of this type, I'm going to talk you through using the notes tool, and this explains to you how to interpret the chart. So if you want to interpret a chart of this type that we've used in this interactive tool, then we're using the relative index of inequalities to indicate the extent to which the rate of an activity or event varies across socioeconomic groups defined by the deciles of deprivation, which Naomi referred to earlier. And this is similar to the idea of a range, but it takes into account the values for all the deprivation deciles, as well as the population size of each group. So the smaller groups don't unduly skew the results. And where the denominator of the rates assessed is the population size, then the relative index of inequality measures the degree of inequality. And where the denominator is a measure of need, the relative index of inequality is the inequity. So in terms of interpreting the chart, when you look at each of the indicators in the chart, where the points are on the left-hand side, they show a greater benefit to the most deprived areas. In other words, the inequity favours the most deprived. And where the points are over on the right-hand side, and they're blue, then they show a greater benefit to the least deprived areas, and the inequity favours the least deprived. And the distance that the points are from zero, whether that be to the left or the right, show the magnitude of the inequity. So for example, in this illustration here, indicator number 2 shows more benefit to the most deprived areas than indicator 3. Turning to the main chart, then what you can see here is that when you look at the metrics on the CHD pathway, you can then see the metrics that appear on the left-hand side in yellow are favouring the most deprived areas, and the metrics that appear on the right-hand side in blue are favouring the least deprived areas. And where the metrics are completely in grey, those are where they straddle zero, and in the case of those metrics, they're considered that there's no evidence of inequity because the variation is great, and in some cases it's to the right of zero, and some cases it's to the left. The tool itself, then what this allows you to do is select an ICB. So the first position is that it shows the chart for the whole of England, but if you want to look in detail at your individual ICB, then you can select that from this drop-down list here. And if you select an ICB and click Generate Chart, that then recalculates the chart and shows the same data and the inequalities and inequities for that individual ICB. And you can see here in this example that I've just chosen that there are quite a lot of metrics where there is no evidence of inequity, and that's going to happen when you look at a smaller area, because the numbers and the amount of data involved is smaller. It doesn't mean that there's no inequity. And in fact, this is why we've incorporated the functionality to alter the confidence interval, because the default position of this chart in the tool is that the 95% confidence interval is shown. But if you want to lower that confidence interval, for example, if I slide along here to 75% confidence interval and regenerate the chart by clicking on the button, you can see then that more of the metrics are showing some evidence of inequality and inequity. So that's why that functionality has been incorporated into the tool. I'm just going to put that back to England, and just remember, every time you want to recalculate the chart, you need to click on the Generate Chart button and the chart will be recalculated. And the other functionality in the tool to demonstrate is that we've also got the option to download the chart and to download the data. So if, having generated the chart and double checking that here the explanation for in the title of the chart matches what you've selected on the left hand side, you can download a copy of this chart by clicking on the Download Chart button. And you can see that at the bottom here, that then generates a PNG, which you can then use so a more printable version, if you like. And then also I can click here and download the data, which puts the data behind that particular chart into a CSV file, which you can open, and that data is then available at the actual data behind each of the metrics. So there's one more thing that I needed to show as well, which is that within this tool, there's the option to hover over. So as you consider each of these metrics, whether that be for the whole of England or for your individual ICB, if you want to look in more detail, for example, if I look at this metric here, emergency admissions for CHD, if I hover over on the individual metric, I can see the value for the relative index of inequality for that metric, which in this case is 0.163. Or I can also look at the lower confidence interval level, or I can look at the upper confidence interval level. And at the moment, I'm selecting 95% confidence interval. So what that's saying is that with the 95% confidence interval, we think that the value is around 0.16, and that's showing the range there from the upper to the lower confidence interval. And it also just highlights for you that the inequity favours the least deprived. And if I hover on the readmissions within 30 days, then I can see that the same thing happens there. I can see the data for the value, the lower and upper confidence intervals, and that the inequity favours the most deprived area. So that's just another way to help you more easily interpret the chart.
So as you can see, while some of the analysis is complex, we hope that the chart is easy to use and has some notes to guide you along the way. We want this tool to be used by analysts in conjunction with the context of each ICB area to better understand why there are health inequalities along the coronary heart disease pathway and how to address them. So we hope it's used to inform ICBs where in the pathway to funnel resources and reduce inequalities of CVD over time. Our next steps are going to be to do similar analysis, but looking along the pathway from the perspective of ethnicity, which presents some methodological challenges, and we're working with the Race and Health Observatory to explore these ideas. Thank you very much for your time, and let us know if you have any questions.
Thank you. Okay, so that's the video that we wanted to show you, and then as well as the video, we did have a couple of other things that we thought would be useful to just point out to you and talk to you about before we go into question and answers. So I'm going to reshare my screen, showing you the tool itself live in action. I can get that to work, so that I can just talk to you about a couple of other things. You should now have sight of the tool, all being well. Yeah, I can see Rachel nodding, so that's good news. Yeah, I just thought it was worth also mentioning that when you look at the presentation of the data in the tool, that what we've done with this hang on, done with this particular chart is we've grouped the various metrics. There are, I think, just over 30 metrics in the tool. We've grouped them into different categories along the CHD pathway. And you can see those here on the right hand side. So risk factors, such as smoking, or risk identification, so smoking, obesity, diabetes, depression, CVD risk register, so presence on any of those registers, then those are counted as all under the banner of kind of risk factors. And then there's primary prevention, such as being prescribed statins or having smoking cessation support. Then there are factors such as disease identification, being on the CHD register, having electrocardiography, for example. Then there's also secondary prevention, which would be getting antiplatelet therapy or getting being immunized against flu, or outpatient appointments. Then tertiary prevention would be things such as having elective procedures or cardiac rehabilitation, and then the intermediate outcomes, and finally mortality, and looking at whether that's premature, in other words, like under the age of 75, or not. So the tool is organized in that way, and then the other thing we thought would be useful to point out is just to show a little bit of the findings that you can see from the chart, which is something that wasn't in the video. And what you can see here is that patients from the most deprived areas are more likely to be identified with risk factors and placed on a register, and that patients from the least deprived areas are more likely to receive secondary and tertiary preventions, such as you can see here, flu vaccination. So people are from the least deprived areas are more likely to receive a flu vaccine. People from from the less deprived areas are more likely to get an elective procedure. But yet that premature deaths are more likely amongst patients from the most deprived areas. And so that they were just a few of the findings that we thought would be useful to just sort of highlight to you. And I'm just going to hand over now to Naomi, who is going to just speak to you a little bit more about how the tool can be used.
Still recovering from watching myself for 10 minutes. But yeah, so as I kind of said in the video, I hope that people use the tool to look at where in the pathway, and think about, in the context of the ICB that they're looking at, where in the pathway the inequities are and how you might resolve them. It's interesting in the national picture that while people in the least deprived areas, we kind of know that risk factors are worse in the most deprived areas, but then people in the most deprived areas are benefiting from things like smoking cessation and statins. But then as you move through the pathway, it seems like people maybe in the most deprived areas are dropping off, receiving fewer cardiology referrals, and getting less diagnostic care. So thinking about in the context of the ICBs and also learning from which ICBs are doing it well and comparing in that way. So hopefully, you know, the data downloads will help with those comparisons, and the tool will help with that. And I'd be interested in, and I know we have a few Menti questions, but I'd be interested in hearing how people get on with the tool and how they do find using it, what they're using it for. That's it from me.
And I was just going to also show you actually what you don't see on the video is the downloads themselves. So I did just pre-prepare Blue Peter style. So so this is the, hopefully you can see this. So if you click on the data download button, this is what comes through. So each of the metrics, you get the RII, then you get the upper and the lower, and you get the name of the metric. So that comes through. So this example here is for the whole of England, but then if obviously you get that for each ICB, and then the chart comes through as a PNG, which you can obviously then, you know, drop into a Word document or a PowerPoint presentation, and so on. So that's also a sort of a useful presentation that you can get from the tool. So I think from now, the next thing on our kind of little agenda for the session was that we would kind of open it to any questions, which myself, Naomi, and Stephen will try our best to answer if you have any.
Thanks very much. That was really interesting. We've got somebody with their hand up. So Becky, do you want to ask your question?
Yeah, sorry, I don't have access to the chat, so I have to come on camera. And I just wanted to, I guess it's a couple of questions. And one is about this distinction between inequality and inequity, which, you know, being someone from public health, I do understand that distinction, but sometimes I just need to go back and crystallize what that actually means sometimes. So I just wondered whether, you know, for the rest of the audience, you might want to elucidate that a little bit more. Also, because I think it ties in with my next question, which is about the methodology. So in terms of the inequity bit, I just wondered whether you could go into an explanation of how you've used the measure of need to look at the variation in access to things like services, and just kind of bring out that distinction a little bit more, both conceptually and methodologically, if that makes sense. I think that'd be really useful to me. I don't know about anyone else.
Who wants to pick that one up?
Do you want me to?
You can do, yeah.
Although
That's
I might
fine.
struggle on, although it's a sort of concept I think about a lot, I might struggle on the fly to try and articulate it, but I'll try my best. Bear with me. If we think about the distribution of a particular service intervention across a series of subpopulations, then we might find that some subpopulations have greater access to that intervention than others. And so we might see the distribution of that service therefore being unequal across those populations. That might be perfectly acceptable because the distribution, the unequal distribution of the service might be reflecting the underlying needs within those populations. If that's the case, the distribution is equitable, even though it's unequal. So the key distinction between equity and inequality is that equity attempts to adjust for the levels of need within a population, whereas inequality is just noticing differences. We're not making any value judgment about whether those differences are good or bad. But if you get inequity, i.e. a distribution of services which don't follow patterns of need, then I think you can draw a conclusion that's not a good thing. You know, there's something wrong about the way we're distributing services. Services should be distributed relative to need. And so in the tool, the denominators for most of the metrics we use are the numbers of people with coronary heart disease, i.e. the number of people who might benefit from the interventions on the pathway. The exceptions are the very early parts of the pathway where our denominators are the population. When we're talking about risk factors, then we're taking account of the full population. So we're not saying that how many people smoke relative to the number of people with coronary heart disease. We're saying how many people smoke in that population. So the exceptions to the rules are the early parts of the pathway before the diseases emerge, and therefore need can be identified. Does that help? I don't know whether whether that answers the question. Rebecca, is that?
No, it does,
yeah,
and
okay.
that's great. Thank you. Yeah, you've just confirmed for me my understanding really, so that's been really useful. Thank you, Steve.
Can I add just one thing? Jacqueline, would you mind sharing the chart again, the main chart? Because I wanted to offer a slightly more, maybe sort of health policy opinionated view of how I read the chart and what it's kind of telling me. So I'm stepping outside of the data a little bit and trying to say what does this tell me really about what we're doing? So we all know at the end of the CHD pathway, people living in more deprived areas seem to have worse outcomes. And one of the questions we've got is whether the health services interventions are ameliorating or exacerbating or contributing to those inequalities. And generally speaking, there are more blue points on the upper part of the chart than there are yellow points. So the health services, unfortunately, is making matters worse at most parts of the pathway. It's skewing services towards people living in more affluent areas, and therefore contributing to the inequality we see at the end of the pathway. If we're going to offset that, we need more and more of the chart of the dots to be grey, or ideally yellow. That's what I would want to see. If we're going to move the bottom of the chart to the left to introduce more equity in terms of final outcomes, then we need to skew more of the interventions in favour of people living in more deprived areas to try and readjust the balance, to try and offset some of the wider societal impacts on people, so that the health services contribution is making matters better rather than making matters worse. And there are some good signs here. You know, it's some parts of the primary prevention pathway, some parts of rehabilitation. It looks like we're managing to do that, but on lots of the parts of the pathway, we're actually making matters worse in the health service rather than better. That's a very broad brush reading of the chart, but that's the way that's what I take away from it.
So if there's no other questions from the room, thanks Stephen. There are 1 or 2 points which have been raised on Menti, if I can share those with you. And you can decide between yourselves who's going to answer those. Let me have a look. It's just probably easy for me to share my slide actually, so you can read them all by yourself then, can't you? Pick the ones you like the most. Let's have a look. Here we go. So I'll pick up that one called test. That was me thinking I'd broken everything. So if you just want to go down the left-hand column, so I'll read them. So in order. So the first one is asking if you have any plans. In fact, I know you've only just finished this one, but do you have any plans to look at a different topic, for example, COPD? Maybe not Heart Foundation, but it's all, it's all relevant. Jacqueline.
I'm not sure exactly, but I know we're planning to look at something that's the same pathway, but looking at ethnicity rather than socioeconomic factors. But in terms of pathway, I'm not aware, but maybe Stephen knows something I don't know.
Well, just to say, we had an email yesterday from somebody working in Manchester who's obviously trying to tackle this problem, but he's thinking about the COPD pathway, respiratory pathway. So they've asked to meet with us. I guess they're wondering whether the approach that we've taken might be suitable. So I'm going to try and arrange a conversation with them if that looks like they are approaching it that way. We'll share that through the network if it looks like they're.
So the answer is very possibly. Okay, so another point here, I can just pick things up and just being aware of the time that you got 1 or 2 questions that you want to ask us all as well. There's a question here about would there be any possibility of adapting the tool for use in sub-ICB areas? Is it ICB level at the moment? Is that how it works?
At the moment, it's ICB level, and the data that we used to was gathered at GP practice level. So obviously, you can link each GP practice to a sub-ICB, but where the issues start to arise for some of the metrics when you get to smaller areas because of the amount of data. And so
you'll have long lines.
Yeah, because we for example, where we've got when you go to the ICB level, we have more where it's saying there's no evidence of inequity, but that can be linked to small amounts of data. And obviously at sub ICB level, then you would get that would be an even greater factor. So so I'm not sure if the others have got any other thoughts on that.
Stephen?
Well, yeah, just to confirm, I think the unit of analysis, the primary unit of analysis, the GP practice, or anything that be built up from that, in theory, you could represent in the same way that Jacqueline and Naomi have shown for ICBs, but you'll have that challenge of more noise, smaller sample sizes, bigger confidence intervals, more difficult to draw definitive conclusions about where the inequity lies. In part, the reason why, as Jacqueline said, we've put that slider on for the confidence interval is because we want to give people the opportunity to lower the threshold by which they form a judgment about whether inequity exists. But you only take that so far, really, before you start beyond 50-50. I'm not sure there's any value in it.
Yeah, sure. Okay, thanks for that, Stephen. I suppose you could. There may be there could be subgroups, sort of groupings of GP practices, which might make sense for some elements of the pathway and not for others where the numbers are low. So there might be a bit of potential there, but there's a balance, isn't there, between what would be useful and what would be misleading. And yeah, just because you can break it down doesn't mean to say it is the thing to do. Okay, great, thanks very much. A couple more questions here. Any particular challenges when you were developing this tool? I imagine it was all plain sailing, and that is a pretty redundant question. Who wants to pick that up? Who wants?
I'll go first, but the others have probably each got their own different ideas. I think mine were with sort of maybe like some technical, in that I was using tools where I was simultaneously like doing the work and developing skills at the same time. So for me, that's where the challenges lay, which is probably not really what the question was getting at. So maybe the others have got some other thoughts on that. And I think just gathering, probably just kind of gathering all the data into the right format, and sort of selecting exactly how to sort of represent each metric. But the others have probably got their own ideas.
I would say similarly, the data gathering to get everything at the same level can be difficult, and yeah, sometimes you have GP level, sometimes you don't, and mapping that to deprivation can be challenging. I've done similar analysis which had the same challenge. And then presenting the data, I think, was also a challenge for us, was figuring out, because we didn't go into this, but some of the indicators in the tool are positive things and some of them are negative. You know, if you get a diagnosis, that's a positive thing. So some are benefits, sure, and some are disbenefits, and we had to there were some methodological challenges there, which we had a lot of conversations about, and I think came up with a solution that worked.
Yeah, the polarity, just making sure it's the right way round. This is good,
Yeah.
isn't it? This is bad, isn't it?
Yeah.
Yeah.
Okay.
And just to add to that as well, we came up with, I think, like 4 different like presentations of the chart that we had to like meet and discuss and choose between. We didn't all necessarily agree on what we each had different views about, probably about what we saw as as what made sense in our own heads, and it was trying to think of which presentation would be the most kind of readily accessible to the audience for the work.
Did you test it out on potential audiences? Did you just sort of work it out for yourselves, and how did you test out which was the most appropriate or best way of presenting all of this data then?
Yeah, that's a good question. I know we looked at it at the British Heart Foundation. We tested it like in our team, which is still analytical, but there were still, there were some that were more confusing than others. And my former boss always tests things on her mom. She says her mom is a great test case.
that would be Kate's mum, yeah. Okay, great. Anybody, if I've got a few other questions, if anybody, should I move on to the next 1 or 2 questions that we've got here? Are you sharing, are you publishing and sharing your code for calculating? Oops, sorry. Can you see the question?
Yeah, for calculating the relative index of inequality. I don't know if we're publishing the code, but all of the methodology, and we can send the links. I don't know who, I don't have access to the chat either, but I guess we can send the links after or put them in Menti. But there's a downloadable report, and the methodology is also in the tool, so that explains the relative index of inequality.
Okay, thanks. Yeah, we'll. Sorry, Stephen.
I'm going to commit us to sharing the code. I don't know whether Jacqueline's going to throw something at me, but yes, we will share.
Excellent. Well, we'll make sure that happens then. So another question here. I think we've got time for about 3 more questions. So really importantly, who's going to be using this tool? Who's it going to be most useful to? And there's another question here about from an analyst, public health analyst, how would they use that tool? So this is about how is it? It's not. I'm seeing this not as just for analysts. This is something for analysts to talk to others and explain and help share the messages.
Yeah,
Who's
I think that's exactly right. I think it will be, the tool itself will be probably most useful for analysts to then translate and kind of give to decision makers as here's what our area or this area is saying. And in terms of effectively using the tool, I think it's going to be like exploratory and taking comparing different things, comparing an ICB to the national picture, and really contextualizing it so it isn't all about the data. The data is really useful to kind of send you down the right path, but then to contextualize within the ICB, like looking at the bigger picture in each ICB, I think will help the tool become effective in eventually reducing inequality. I don't know if Steve or Jacqueline has anything to add to that.
I guess we were thinking of CHD leads in ICBs or sub-regions as being the main audience for the tool. And yes, we just kind of wanted to give people just a steer about which interventions they might want to focus on redistributing if their objective was equity of outcomes in CHD pathways and CHD outcomes. I guess in a local area you'll want to do your own work just to reassure yourself that any given result that we might be representing by a metric in your ICB is a genuine result, not an artefact of the data.
That's hilarious.
Somebody walked past me today.
Are they ringing a bell in behind like this?
I'll go on.
No, it's fine. It's fine. No, that's helpful. Sort of a couple of the questions. One's on here, and one isn't. So, you may have sort of covered it in your presentation, but were there any actual sort of surprises in the results of what you found when you sort of were analysing it in the way that you have and presenting it in the way that you did?
I thought the most surprising thing was that people in the most deprived areas did get preventative treatment, but then fell off the pathway, because we always talk about prevention and prevention being such a key thing, and it is, but it was very surprising to see that on the prevention side, we're actually doing okay when it comes to addressing that in the most deprived areas, that things fall off a little just after that in terms of diagnosis, and then treatment and emergency admissions especially are kind of a result of the missing link of sending people in the most deprived areas for cardiology referrals and diagnostics.
And Stephen, this is the same kind of pattern that you found when you did your report on the inequity of access to, well, it was elective care, wasn't it? But I think there was that surprising presentation or representation of people from more deprived areas lower down or further back in the pathway. And then when it came similar to this, when it was further on for procedures, it tended to be the other way around. So there's a bit of a shift. So I would have been surprised to see that, but because Stephen did all that wonderful work, I wasn't surprised to see that. But I think it's good to have things sort of confirmed, really, so we can really properly understand what's going on. Just one more question, I think, before I'm going to hand over to Glenn Howard, who's going to tell us about some training that he wants us to be taking a look at. And so have we got a link to the tool, which we're going to be sorting all that out. So the only other question that I'll pick up from here, and I'll just stop sharing, is in terms of the updates. So is it sort of a one-off tool? Here you go. Here, this is how you update it, or is it something that you're going to be updating? Are you looking at the position over time, or is it a snapshot?
Oh, go ahead, Steve.
Well, I guess it's a little bit of an experiment, this tool, isn't it? We're trying to see whether or not people do find it useful as a means of examining where inequity emerge on the pathway. My guess is if it gets good uptake, then it is something we will come back and update. And if not, we'll probably try and find other ways to try and tackle the same problem. But yeah, that was, I don't know, a name, or whether you've got any alternative views on that. But,
yeah, I would just add that looking at over time can be difficult because the indicators change, especially QOF indicators change. And so that is why at the moment it is a snapshot. And also inequalities move really, and inequity moves really slowly. So I don't think it is something that we would want to do annually, but maybe once we see how it lands and how people are using it, we can consider, every 3 years or every 5 years doing an update.
Okay, thanks very much. Of course, I've just realised as I'm a terrible host, you did have some questions that you wanted to ask the audience, and I have to leave a little bit of time for my friend Glenn to tell us about his training. But I have moved the Menti on. If we can just have a little look, a brief look at the questions that our presenters would like to ask you. The first one is who among your non-analytical colleagues do you think would find this most useful? The shortcut to this is I'll give you the answer because Stephen's already mentioned it might be the CHD leads, it might be sort of people who commission services or support that recognise within that pathway where they sort of intersect with it, where they can have an impact. So it could be a variety of people, and in fact it could be people who are not specifically CHD, but more broadly they are interested in the disparity, the inequity. Hello, Postman. Across the pathway. Sorry. Eddie, be quiet. There you go. He saved me again. So another program lead. Yeah, exactly. So I'm using all the wrong terms. So people who can use that information to target certain target their services and their support in a different way to recognise where they need to put more service in. Thank you very much for that. So another question would be, is in fact, what other metrics? So this is something that you must have discussed at length. What other metrics could be added in to this this tool? Just with a reminder that it needs to be available at GP practice level. So there may be something that people find in their experience that is missing from the tool, or that could enhance it as well. So that, but I think you would be interested to have people's views on that. And then the final question, so I'll leave that hanging. But I'll tell you what I'll do. I'll share these questions with people afterwards, so that if they do have a view on it, because it does feel like as a pilot, you'd be interested. Okay, we've got CVD prevention data on there. It'd be something that you would be interested in receiving from, because we've got a lot of specialists in the audience today, some public health analysts in the audience. So my last slide is just a quick one that people can interact with before I hand over to Glenn. And are you going to make use of the tool and the analysis that it presents? So I've got somebody saying yes, definitely. I've given people the options. I do recognise also that because I was messing about with the Menti, you might need to refresh it, because I was changing the order of some of the questions. So hopefully people are able to refresh it and get to the right questions. There's people saying they definitely use it. Some people saying they would like to find out more. But there's mostly it's. I'll let you see this just so because you're looking like you don't believe me. There you go. I think it's fair that people would want to find out more. So I think it's, if we can follow this up with a way of people finding out more about this as well, I think that would be a good action to take following this meeting. Okay, well I'll stop my sharing. I'm going to
Rachel,
yes.
Can I just interrupt you briefly? Just say I have put a link in the chat to
Okay.
which from which it's to the BHF website actually, and from there you can get the accompanying report, and you can access the tool.
Brilliant. I will share that with everybody after. Not everyone can see the chat, so I'll share that with via email and on Teams afterwards as well. Maybe I'll put it on the internet. Okay, thank you very much for coming today. I've enjoyed your presentation. It's an excellent tool, and I'm sure people are going to be using it. We've got 1 minute, Glenn. What have you got to say?
Brilliant, thank you, Rachel. And again, if you can send the link out to everyone to the so people know the East Midlands Academic Health Science Network has run for a number of years a information analyst development program. That's a 10-day program delivered remotely over half days. We have some funded places, so that will pay the course fees for you. And we have a number of places available, and applications for that are open until the 26th of January, and the cohort starts in February and March. So we just wanted to let people know that this opportunity is there. I managed to get funding for a couple of cohorts, so please encourage people to apply. The more people apply, hopefully the more I'll have in the business case for asking for funding for next year. So I want to make people aware of the opportunity, and if anyone's got any questions, I can hang around for a couple of minutes, or you can drop me an email, and I'm more than happy to answer them. So hopefully that did within 1 minute.
You did, and I'm sorry I didn't give you. I'm sure I promised you at least 5 minutes. Terrible. How awful of me. Time management 0. No, thanks very much for that, Glenn. So it's a really good course. It's been going for several years, and people love it. So I would recommend people to apply for it. And
just to clarify, it's open to any analyst in the Midlands because it's from Midlands funding, but in any sector. So really public sector, but it's suitable for health, social care. Anyone that's using health or care data will benefit.
Thank you. That's marvelous. It sounds like a great course. Thank you very much, Glenn, for sharing that with us. I did email everybody the link the other day. I'll include it on my follow-up to this huddle as well. Thanks, everybody. Enjoy the rest of your day, and I'll see you all in a couple of weeks. Okay, bye-bye.